Welcome to On Health with Houston Methodist. I'm Zach Moore. I'm a photographer and editor here, and I'm also a longtime podcaster.
I'm Katie McCallum, former researcher turned health writer, mostly writing for our blogs.
I'm Todd Ackerman. I'm a former medical reporter turned editor here at Houston Methodist.
I'm Kim Rivera, Huston-Weber, and I'm a copywriter here at Houston Methodist.
Hey, Kim, do you get migraines?
I do. Ever since my late teen years, it's just been something that has been kind of part of my life. They're not fun.
No, I wouldn't imagine so.
when you're getting them, like how often are you getting migraines?
I've had them as often as maybe like 17, 18 times a month. And then I've had them as few as like a few times a month.
Okay. Wow. I thought you were going to say like 18 times ever.
Right. Or in a year was going to be my...
Yeah. And, I think that's
crazy.
an experience that a lot of women have because I think migraine predominantly affects women. So I have lots of friends who actually experience migraine too. And they're kind of similar where some of them have a lot every month and then some of them just, once a month, usually around their lady time.
So have you picked out any triggers or anything? Because I think a lot of what I've heard is that people are like, oh, it's because of this. But then you're always you do so many things. So have you narrowed down any triggers or anything? Or is that real? I don't know if I'm making that up.
No. I think it's really true that there are certain things. One of the times most recently that I got one, I was actually I was doing a ride share. And the driver had it seemed like he was swimming in cologne. And I stepped in and I was like, this is going to be a problem. The window's up. It's Houston in the summer.
Okay,
yeah.
No escape.
No escape. On the highways too. It was terrible. Sometimes if it's too bright, certain places, the weather is a big trigger for me. So now that I live here in Houston and it's just hot all the time, I have those less, but those have been some of the big triggers for me.
Yeah. And I mean, so I have another question for you because, I don't think I've gotten migraines really, but everyone's had headaches. So on a scale of 1 to 10, where would you rank migraine in terms of everyday headache or maybe hangover headache? Because I think that's the one I think of. It's the worst, but you tell me, is it the worst?
I would say hangovers probably on a spectrum too. I would think about the worst hangover you've ever had where if you were vomiting or having something like that, I think that's more on the migraine spectrum because I do get them where I get sick. I have to have blackout curtains.
Go in a dark place, lay down, just experience nothing sensory except for your body physically existing.
Exactly.
Yeah.
Now, Todd, you're quiet over there. Have you had a migraine in your time?
I think so.
Well, if you think so, you probably haven't, right?
No, I've always thought if you've had a migraine, you know it.
Well, there you go.
This very notion of this podcast seems to call that into question.
Okay, I see.
I don't get migraines generally, but there's one I suffered, I'm pretty sure I suffered 30 years ago that's still distinct in my memory because it was so intense.
Wow. 30 years. That is an intense headache.
Yeah. And it seemed like a migraine, even though I thought one of the definitions of migraines was you get them regularly. But this one time seemed like a migraine because of the sheer intensity of it, the fact that I was nauseous during it, and that light was so bothersome that I had to do the whole sensory deprivation thing.
And it was out of the blue?
I had traveled to high altitude, which I think people where I was thought that was a common trigger.
Okay.
I may have had other migraines in my life, but that's the one that really stood out. And I generally suffer from occasional sinus headaches. To me, those seem easy to distinguish from that migraine I had.
Yeah. Well, and people that experience migraine, their brains are they have the ability to tip in to that migraine. So they're just more prone to it. So it seems like there's a lot of lifestyle factors that can help you lessen how migraine affects you. So I don't know, Todd, maybe your brain does have the propensity to tip into that migraine, but you've got that clean living going on that it's keeping you.
Perhaps my mother suffered from migraines or headaches anyway. I don't know if they were migraines, probably. She took a lot of aspirin, I remember.
Yeah. And, I think that's one thing. It's hereditary. So if your mother did indeed experience migraine, you probably do, or at least have the propensity to do so.
That's interesting. Just because it seems so rare to me.
Yeah.
But Kim, who did we talk to today about migraines and headaches?
We talked to Dr. Julia Jones, a neurologist here at Houston Methodist. We're here with Dr. Julia Jones, neurologist with Houston Methodist. Dr. Jones, thank you so much for being with us today.
Thank you for having me.
So in my experience, I've heard people use the word migraine when they actually mean severe headache or bad headache or my head's killing me. And as a person who experiences migraine, I know there is a distinction, but I also know that headache can be as painful to the person that's experiencing them. And even though they might not have the right words to express what's happening to them. So I'd like to start by asking some definitions. What is a headache and what is a migraine and where is their overlap?
So a migraine is a primary type of headache, and we define a migraine by certain criteria. You have to have at least 5 headaches. They're usually of moderate intensity, interfere with activities. When you walk around, cough or sneeze, aggravates the headache. You have to have some degree of light or noise sensitivity or nausea. So we define migraine by those criteria, and they are genetic. Now, a headache could be many different things. It could be whammo, frying pan hit my head, worst headache of life, and that would be suspicious for a subarachnoid hemorrhage related to a cerebral aneurysm rupture. So there are different headaches, but the primary headaches, cluster, migraine, tension-type headaches, or are defined by those criteria. But their headaches have ominous features, sudden onset, severe, progressive, and obviously have other causes.
That leads me to my next question. What causes migraines, and do the causes seem to differ from other types of headaches?
Well, as far as a migraine headache, we know they're genetic. If mom or dad had it, you've got a good chance of getting them. We know that migraine brains are basically hardwired to tip into that headache. So more prevalent in your 30s and 40s, often start in your teenage years. But they've done cerebral blood flow studies giving someone nitroglycerin and looking at migraine patients, and they have stronger connections between that hypothalamus and autonomic and pain centers. So we know they're kind of hardwired, as I say, to sort of tip into that headache. As far as tension-type headaches, cervicogenic headache, they may relate to more muscle spasm, musculoskeletal issues with the shoulder, neck, or jaw.
Which headache types most often get confused with migraine?
I think sinus headache would be one of them, in that people will have a headache, they have pressure in their face, they go see their ear, nose, and throat doc, and lo and behold, their sinuses are totally clear. And in fact, they probably have migraines. Some of these patients may have dizziness, which we can see as a feature of migraines, but they may have frontal pressure or pressure in the cheek, because a migraine can be anywhere above the shoulders as far as the pain. And sometimes we'll have activation of nasal congestion, even flushing or tearing with a migraine headache. But now, actually, if you have a sinus infection, a headache is a minor feature. You're sick. You've got green stuff coming out of the back of your throat or your nose. A headache is a minor feature. The sinus infection will not go away with Tylenol or a migraine medicine. It goes away with an antibiotic. So I think that's maybe where I see most of my patients coming from an ENT. They don't have sinusitis or sinus headaches. They have migraines.
And kind of to that point, I always like to say that my husband can predict the weather, because whenever there's a drop in barometric pressure, he gets a headache. Is that more sinus headache? Is that more migraine? What would you say that is?
I would say that's pretty typical of a migraine if they meet those criteria with the features. So a lot of patients will tell me, I know the weather change is coming before the weather guy does on TV. And so there have been studies, and I think it does correlate. It's, there are many triggers for migraine patients, and the hypothalamus is what kind of controls our homeostasis. When we're tired, we're hungry, etc. And so, emotional stressors, hormonal change, odors, etc. All these things can alter our homeostasis. And weather change is listed as not an uncommon migraine trigger. And I've had a lot of patients who are real happy this summer because there's been no weather change.
Yeah, I've been pretty excited. It's been the only exciting thing about the weather just being blazing hot. Now I know definitively that weather can be a trigger, but what are some of the most common migraine triggers that exist? And what are some of the not so common ones you may have seen in your practice?
So, as I mentioned, we're kind of hardwired to tip into those headaches when your hypothalamus is not happy. So ideally, make it happy by normalizing your meals, your sleep, your exercise. Probably the number one trigger would be stress. Sometimes we don't know we're under that stress until it's kind of behind us. People are having headache with their job and their boss making them crazy. They go away when they change jobs. Stress letdown. Yay, finals are over. I'm on vacation. Yay, boom, there's a headache. So stress letdown. Hormonal for women, ovulation menses, very common. Usually it's that withdrawal of estrogen once a month where you get menstrual migraines day 2 or 3 of your period that can actually be more severe than headaches outside of that. We'll also see it with being off with your meals, such as you were late for breakfast, you waited for the breakfast tacos at work, or you skipped a meal. And then sleep pattern variability, different time zone, my shift workers, nurses, bus drivers, police officers, or you just decide to sleep on your Sunday. Those can all be migraine triggers. Also, people will note triggers such as odors, smoke, incense, candles. I know there's certain stores I do not like to go into because they smell. Also, 26% will find a food trigger. So only 26%. But it's nice if you can find that out because you can avoid that trigger, meaning chocolate, aged cheeses, smoked meats, nuts, additives and seasonings like in marinades. We can see it with the processed meats, the nitrite, salami, bologna, hot dog, bacon, the tyramine foods. Those are the other ones I mentioned. And they've also done studies. And okay, let's see if we give you a headache. Here's your chocolate bar. Well, you didn't have a headache, but 3 months ago, horrible headache. Well, 3 months ago, maybe you hadn't slept. It was your period. Didn't feel so hot. Boom, chocolate. You got a migraine. So identical triggers may not always trigger a headache. Go figure.
Yeah, it's wild sometimes when you experience something and it's not one of your usual triggers. Are there other conditions that may lead someone to believe that they have migraine or maybe chronic headache when they might not?
Well, I think if someone has a new onset severe headache, they might think of a migraine. We know that less than 5% after the age of 55 will have the onset of migraines. They're usually younger, 20s, 30s, 40s. So if you're having a late onset severe headache, they need an investigation into other causes. Is there a stroke, a tumor, hydrocephalus, or what we call water on the brain? Something else that's not so good.
Before we talk treatments and prevention, and you kind of spoke to it there, can you share when someone should seek care for either chronic headache or migraine?
So migraine headaches are like I said, fairly prevalent in your 30s and 40s. A lot of people get relief with Tylenol, Advil, so they're probably not the people who need to come in and be seen. If they can get rid of their headache and they can function well. I think it's someone who's having more frequent headaches that are not responding to over-the-counter medicines that they need treatment either with their primary care physician or seeing a neurologist. For instance, no matter how perfect your day is and how happy your hypothalamus, about a third of patients with migraines will need a prevention, something to turn them down and make them less frequent and or severe. So it's important that they get in with their doctor because we have a lot of new treatments that are out there that target treating the migraine.
Managing migraine or headaches can be somewhat of a personal affair. I've talked with several people who experience migraine and asked what various natural or homeopathic methods they've used to deal with pain, whether it be a warm bath, peppermint oil on the temple, warm rag on the neck, and a cool rag on the forehead. I've heard everything. Someone even told me that when they experienced migraines as a child, that their grandmother told them to submerge their feet in really hot water to pull the blood away from your brain. I'm sure you've heard it all when it comes to migraine pain management technique. So when it comes to home remedies, what actually works versus what might be a placebo or just something that is self-soothing?
So I think with a migraine patient, a lot of them have light and noise sensitivity. Typically, they'll go into a dark room where it's quiet and it's cool and no one bothers them. Hopefully, they can take an anti-inflammatory or Tylenol that works for them if we're doing at-home treatment. Some patients will get the frozen peas and put it on their head, and hopefully that will work for them. Often sleep will relieve a migraine headache. If they can get some sleep, knock out a little Benadryl, they may wake up without a headache, but not always. As far as homeopathic sort of preventatives, there is magnesium oxide. Some will take about 420 milligrams at bedtime. That can help them sleep, and it does have Class B efficacy for migraine prevention, in addition to vitamin B2 or riboflavin. About 200 milligrams daily. So if someone is potentially planning pregnancy, those are obviously very safe. Mag oxide, vitamin B2. There's some data, also Class B for CoQ10, feverfew. So we have some other ones that are over the counter. But if someone's disabled, they're laying in bed, I would recommend they get on medicine that treats their headache so they can not have to do that and just function and go about their day.
The American Migraine Foundation says that 1 in every 4 households in the U.S. has someone who experiences migraine. It's also considered the 3rd most common condition in the world, affecting 1 out of every 7 people globally. But unfortunately, migraine can be underdiagnosed and undertreated. The American Migraine Foundation says that fewer than 5% have been seen by a healthcare provider, received an accurate diagnosis, and obtained appropriate care. People may believe they're having sinus or extreme tension headaches and taking over-the-counter medicines too much, leading to even more migraines.
Let's talk migraine treatment types, both those that can help ease migraine attack symptoms and the preventive medications that exist.
So acutely with a migraine patient, let's assume they're coming to see the doctor. They haven't responded to Tylenol, Advil. They may be taking a frequent amount of Excedrin, BC powders. And unfortunately, besides those being able to give you an ulcer, they also can give you rebound headaches or withdrawal headaches when you're not taking the Excedrin or BC powder. So that can also contribute to transforming that headache that's on occasion now to almost every day. So we need to get off the over-the-counters as much as possible. Tylenol probably is the least offensive one to take, but it more than likely doesn't work. So seeing the physician, the acute treatment, we usually go with the triptans, and these are a group of drugs that came out in the 90s. Actually, a Glaxo scientist discovered Imitrex in 1984, came on the market as a shot in 1992. Then all the pills rolled out, the triptans, Imitrex, Maxalt, Relpax, etc., all generic now and very affordable, and they work for 2/3. They're helping out being an agonist at some of the serotonin receptors in our brain. Some of these are on the heart. So some of the contraindications with these older drugs would be coronary artery disease or uncontrolled high blood pressure. But the triptans work for 2/3 of folks who take them. They work in about 20 minutes, most of the pills, Imitrex, Maxalt, Relpax, Zomig. And there also is a spray and a shot, as I mentioned. But they're pretty effective. Now, some of the contraindications besides uncontrolled high blood pressure, heart disease would be, well, if you don't tolerate it. Some of the side effects can include tightness in your muscles, dry mouth, dizziness, fatigue. I've had some patients who just have to lay down with these. So that's not really acceptable. You don't want to take something and have to go lay down. You want to take something that works and you can keep going. So the triptans now are still present and available. And now we have some newer drugs that you see advertised on television, Nurtec, Ubrelvy. And these are a new class of drug called the Gepants. So these work a little slower but have less side effects. So these drugs are working by blocking something called CGRP, calcitonin gene-related peptide. So this is a neuropeptide in our brain. It's also in the peripheral nervous system. It's in our skin. It's in our gut. But we know CGRP plays a role in causing release of the pain factors that give us our headache. For instance, CGRP is increased in the jugular venous blood when patients have a migraine. Injection or intravenously of CGRP causes a horrible headache in migraine patients. And then now these newer medicines, these Gepants, Nurtec, Ubrelvy, are very effective in aborting a migraine headache. And now we also have larger molecule blockers of CGRP. Aimovig, Ajovy, Emgality that work very effectively as a preventative. So acutely, we've got triptans, we've got Nurtec, Ubrelvy. There's another one called Rayval that's out that's new. It's a ditan. It works by agonizing another serotonin receptor. So the last ones I've mentioned, the newer ones, Nurtec, Ubrelvy, Rayval, they're actually stroke and are high blood pressure in stroke patients, whereas the triptans can be problematic. So we have a lot of new acute medicines that are out there. There are even some devices that are used. Norivio armband. It's approved for ages 12 and up. So it's a little band that goes on your biceps. Looks like a little, just a wraparound gizmo. And it stimulates the musculocutaneous nerve, or the nerve for the biceps. You put this on acutely within 20 minutes of the headache, leave it on for 45 minutes. You'll feel a little warmth on your arm. You control it with your smartphone. And this is working by what's called remote electronic neuromodulation. It's sending inhibitory impulses to your brainstem that, guess what, blocks the release of CGRP. So these are kind of neat, and it did just get approved for prevention to be used every other day. Now going on to prophylactics, we have a lot of drugs that have been around for many years. And in fact, most of the migraine preventives were borrowed. For instance, amitriptyline, Depakote, Topamax, Inderal. These are drugs that were approved for other primary purposes, and then they were used for prevention of migraine. So we have Class A data for some of the old school ones. Amitriptyline is a B. Magnesium, I mentioned, is a B. Vitamin B2. As far as other prescriptions, Class A, we've got Topamax, a seizure drug, then approved for migraines. Depakote, seizure drug approved for migraines in 1995. And beta blockers, metoprolol, these are Class A. The other Class A preventatives include Nurtec. That's the one I mentioned that we can use acutely. It's a GPANT. Another one that just came out that's also another GPANT is Qulipta, Class A data. And then we have the large molecule monoclonal antibodies against CGRP. Aimovig, Ajovy, Emgality, and an infusion called Vyepti. And so these are basically binding CGRP directly or blocking the CGRP receptor in the periphery of the brain. So these large molecule injections are very low side effect. They're all Class A. They did not study pregnancy and breastfeeding. So if someone was to say, hey, I want to have babies, you want to get the injection or get that out of their system for 5 half-lives, about 5 months. These medicines are cool in that they're not going through your kidney or liver. I have a lung transplant patient who takes Ajovy. There's no drug interactions. It's broken down at the cellular level. That's why it has such a long half-life. And the side effects are pretty low. In other words, you can have an allergic reaction, of course. It's a little injection you do on the side of your leg, on your stomach. So you can have an injection site reaction or a little red hot spot. We have some GI issues with Aimovig. Up to 3% could have some constipation. It could be severe, although Aimovig is the one that actually is approved in Germany as well. It beat out Topamax and has 5-year safety data. So all of these are very usable medications. Vyepti, the infusion, is the same sort of thing. You have to go to an infusion center every 3 months. It lasts about 30 minutes, and then you repeat it. Those are some of our newer preventatives, and you've probably heard of Botox. Botox got approved in October of 2010, and so it's 31 injections in the face, scalp, and neck region. Botox, was used for cosmetics back in 2002 when it was approved, and they found that patients were having less migraines. So lo and behold, what does Botox do? Well, it blocks acetylcholine so you don't wrinkle, but it also blocks, guess what? Release of CGRP. So that's why we have a certain protocol, sort of what I call shotgunned, but you do that every 3 months.
So this is something that I've witnessed in my friends and my family, and I've experienced it somewhat, that there's just this treatment journey that you go on to find what works and what doesn't, and it's a lot of trial and error when it comes to getting relief for migraine. Can you speak to working with a neurologist to figure out what the right treatment options are?
Yes, I think most of my patients are going to have episodic migraines, less than 15 headache days in a month. And I mentioned, usually if you're hitting 6 to 8 headache days in a month, that's the group I'd recommend getting on a preventive, because we know we can get rebound from some certain over-the-counter medicines. We can get rebound from Imitrex, the old triptans. Now, we don't get rebound from our new ones, Ubrelvy or Nurtec, but about a third of folks will need a preventative. Now, what if you're having more than 15 headache days? We'd call that chronic migraines. So I mentioned Botox already. That's actually only approved for chronic migraine, not episodic. And usually someone has to be a treatment failure with a couple of older drugs or newer drugs. But if all the patients that need prevention, which I said is about a third of those are chronic migraines. Now, certain medicines are approved for both prevention of episodic and chronic. That would include Qulipta. the daily pill, atogepant. Botox is only for chronic. Now the injectables, Emgality, Ajovy, Vyepti, Aimovig, those can be used with episodic or chronic migraines. So a lot of times when I see patients, they've been on old amitriptyline or a beta blocker, maybe Topamax, and we're going to get them on something that's more effective and has less side effects. So usually we'll kind of go through the process. Are you planning pregnancy? There are certain questions you have to know because we wouldn't give the injectables. Something like a Nurtec every other day or Qulipta daily could be stopped pretty quickly and out of your system in a week if you wanted to conceive. Meanwhile, those shots, we said get out of your system for 5 months because we don't know what it does.
Aside from the preventive medications that exist, are there things people can do to help prevent their migraines?
So I think going back to a happy hypothalamus or kind of being chill, meaning you're normalizing your meals. You're waking up at 6 on the weekdays and the weekends, not sleeping in. And if you can do cardio 3 times a week for 35 minutes or even, 4 days a week, but good de-stressor, you sleep better, you feel better. So taking care of you goes a long way. You're skipping meals, you're stressed out, you're not sleeping. That's going to stir it up.
And is there any such thing as being cured of migraine? Can they go away on their own?
Often women, about 60% after menopause, which average age is about 51, will have less headaches or they may get rid of them. Men obviously don't have that. So I think it varies on the individual. I see a lot of patients who, they had headaches when they were kids. They went away in their 20s after they had their baby in their 30s. Here they are again, they're back. So I don't know how to predict that, but we know looking back at those triggers like stressors or variability in routine certainly can be problematic for folks. So I don't typically see someone going completely in remission. For instance, I remember seeing a lady who her cardiologist sent her to me because she'd seen a rainbow in her vision. And she didn't really remember, but she had migraines when she was a kid. But what she had was a migraine aura. The cardiologist was afraid she had a stroke. But in fact, she had a migraine aura, which is very characteristic. So, and she was in her 80s, but she hadn't had anything for years.
I'm hoping it'll happen for me and they'll go away. You've mentioned rebound headaches, and do you hear from patients about migraine hangover? So maybe the next day after a headache being somewhat as bad as the headache, or is that what you would consider a rebound headache?
So I think when we have a migraine, if you can best treat it acutely with what works for you, you have the best bet of not having that. But some people do have the post-drome where they feel a bit fatigued or wiped out or what you said, hungover. And some people can have a little bit of a sensitization. And what that means is if we didn't get that headache treated acutely, the scalp gets tender. It hurts to put on your glasses, brush your hair. So we can certainly see that. So we need a better acute treatment, hopefully, that knocks it out. But sometimes it's menstrual migraine time and you're having a headache every day for a few days and you may need to have some medicine, repeated short-term during that time period.
So when you talk about each person's migraine triggers are probably going to be unique to them. And I'm sure in your practice, you're seeing people and they might be new to their migraine journey and they might not know what their triggers are. How do you help them figure out what's causing their migraines?
So we know the triggers, the stress, etc. And what I ask patients to do is to keep a headache diary. There are a couple of apps that are available, Migraine Buddy, Eye Headache, Allergan has one with Botox. So you can kind of get a feel for maybe what might be triggering your headaches, because sometimes it's unclear. But we know a migraine can actually be cooking up to 3 days before the pain, so that Friday night glass of rosé might give you your Monday headache. So it's kind of a long ways to look back. Most people think, oh, I drank red wine, it should give me a headache right away. Well, not necessarily. So it's helpful to keep that headache diary and sort of see what's off. And then usually I give my patients some information, what I call migraine FYI, looking at the new medicines, going over that, talking about rebound, trying to avoid a lot of over-the-counters. Let's not take what doesn't work. And, when they're seeing me, it's not working. Let's switch gears, steer away from narcotics, butalbital or Fiorset, and then keeping the diary, I think, is very helpful for them because a lot of people will go, hey, when I go to the Astros game, I have peanuts, I get a headache. Then I went to that fish fry, peanut oil. I had a patient who told me that. I'm like, okay, good. Avoid peanuts. Unfortunately, peanuts are in a lot of things. But if you can figure out a trigger, it's good.
It's very interesting because I feel that especially as the newer medications have come out, it just feels like it's really opened up for a lot of people who experience migraine, because I have a friend that it took a really long time. She's doing Botox now, but she had a really hard time with the triptans, and
we've got better stuff.
Yeah, it's really a whole new world out there.
Yeah. Because I started practicing in 92, we had the ergots, Cafragot, Ergostat. And then, Imitrex came out in 92.
Well, thank you so much for sitting down with us today.
Sure. Thank you.
So, Kim, migraines are a big part of your life. And did you find, when talking to Dr. Jones here, did you find validation, reassurance, some maybe new strategies you could try? Like, what was your big takeaways from this?
The conversation was very reaffirming of my experience. And the one thing that I really latched on to was when she discussed lifestyle factors. I wouldn't say, I'm no Todd. I haven't taken care of myself, for the entirety of my life, I would say. I've definitely gone through some like dirtbag phases where, I'm not sleeping well. I'm, not eating well, like all of the things. And surprise, those were the periods in my life
Shocking.
where I
Who would have
had
thought?
tons of migraines.
Just for the record, I was young once.
You had a dirtbag phase.
Well, I don't know if that's the exact way I'd put it, but
Todd, what's the craziest snack you've ever eaten? Pretzels?
when I was
Ritz
a kid,
crackers.
when I was a kid, we got to remember the times here. My mom gave me $1 to get dinner at a baseball, like a local baseball
Well,
game,
it's depressing to think about.
where the idea was to get a hot dog or something. I got 10 ice cream sandwiches.
10
There's a lot to unpack there.
There's a lot of ice cream sandwiches to unpack for one. Wow.
Did you eat all 10?
Yeah.
Do you have a migraine after?
No.
All right.
Well, that's a brain freeze is a totally different
Yes, I
situation.
had that. Yeah.
Yeah.
But no, that's a good takeaway though, right? I mean, like we're always talking about on I feel like every conversation we have about this, take care of yourself and your body will, take care of you, right?
Yeah, for sure. And, the recommendation for working out, and I've been doing more semi-recently, and, I've had less headaches. I mean, I still have headaches every month.
Migraines.
Yeah. See, I did the thing.
Yeah. You kind of lessen it for your...
Yeah. Well, I think it's because sometimes some of them will be, I'm getting sick and there's no way of getting out of it. And then there's, I'm not feeling well. And is it a migraine, or did I just not have enough water today?
Yeah. Well, and to your point too, I like how she talked about it's additive in the sense of maybe this one trigger that's random. Well, it doesn't really bother you unless you're also not sleeping well, or you're also, you have all these other triggers that kind of start piling on. And then things like sleep, exercise helps you sleep. So I don't know, it gets back to this thing where it's all sort of this big circle of like, you just have to be healthy, which is hard, right? It's hard.
Yeah, because being a dirtbag's a little fun sometimes.
It's true.
So for people out there who are listening, who are on the fence if they're having migraines or not, like as someone who has experienced a lot of them, what would you tell them?
I would say if you're having a lot of headaches in a month and you can't really pinpoint why, I would probably get checked out, especially if you're light sensitive, if nothing is really bringing you relief for them, because I think that's another important thing. Like if you're overusing over-the-counter medications, you're just going to give yourself more headaches. And I think that might be the vicious loop that people find themselves in.
Yeah. And I liked one of the telling signs that you mentioned where your husband can tell he's getting a migraine when the weather changes. Mm-hmm. I think that's weird too, right? That should be kind of like a red flag. That's like, if I can start predicting the weather just with a headache, maybe it's a little more than a headache.
Yeah,
exactly.
I like that Houston's weather is actually good for your headaches. That's the first real good testimonial in favor of Houston weather.
You're supposed to say good for something.
Yeah.
All right, that's going to do it for this episode of On Health with Houston Methodist. We drop new episodes every Tuesday morning, so be sure to share, like, and subscribe wherever you get your podcasts. And until then, stay tuned and stay healthy.